Hey, let's start again. I would like to introduce Professor Ron Allison, that is retired professor at Department of Radiology, Oncology at East Carolina University in Greenville, United States, and now he is Medical Director, 21st Century Oncology in Greenville, North Carolina. He has a clinical expertise in radiation oncology and several publications in photodynamic therapy. Thank you, Professor.
Well, thank you, everybody. Thanks for staying. I won't delay lunch, I promise. So I met Vanderlei 2 decades ago, a long time ago. He was just a genius when I first met him. Now he's a super genius, and he's done quite a bit. When I first met him, he was introducing PDT to Brazil, and now look how far it's come. Absolutely amazing. Congratulations on that, and thank you for this invitation. So I live down south in North Carolina. They're very friendly people, so how you all doing? There you go. But Brazilian people are much friendlier, and it's a great honor to be here today. Thank you very much. So we'll talk a little bit about photodynamic therapy for cancer, and if you have any burning questions, you can just email it to me and I won't respond. So we know that PDT is a very, very elegant and simple way of doing a treatment. It's as simple as a drug in a light causing a reaction, and that simplicity has been both a blessing for PDT, but also its shortcoming in the United States, because it's actually quite difficult to get the right drug dose and right light dose in. But the amazing thing about PDT is you can get a very, very good cancer treatment. You can destroy a cancer and preserve normal tissue, so you can do a wonderful treatment for somebody, and you really don't have to spend $10 million, or is that 20 million real for an operating room, or $50 million for a proton center or cyberknife. So for just the cost of a few dollars, you can cure somebody's cancer. And in the places of the world other than the United States, having something available like that is very wonderful and has been a growth engine. But in the United States, we like to spend millions of dollars on infrastructure. So that's the problem. So once you have photodynamic therapy, you have a photosensitizer, which in the case these days is you apply it. I think in the future, you'll just have natural photosensitizers that are used, but right now you apply it, and then you apply light of the appropriate energy and wavelength. You need a little bit of oxygen, and it creates this very interesting reaction, which we'll talk a little bit more about. But that photodynamic reaction ablates things in its path. It's very, very toxic. But interestingly enough, it preserves tissue structure, probably because the photosensitizers don't seem to get into the tissues that regenerate. So PDT is quite good in that respect, and maybe one of the growth engines of the future for PDT will be this fantastic cosmesis and functional outcome rather than the actual ablation. So I hope that becomes reality. So when we practice PDT today for oncology, we have these very strange tools called photosensitizers, and it's amazing to think that there are natural and synthetic structures that can transfer light energy, but if you really think about it, life on Earth is based on light energy transfer photosynthesis. So apparently Mother Nature knows a lot more than we do and has created these very, very interesting things that we can use for cancer treatment. Again, you can make them or you can find them in nature, and they come in various shapes and sizes, but mostly come from plants or porphyrin-based, and interestingly enough, too, are dyes. Now, has anybody, when they were growing up, did you ever write something on your skin and then go outside in the sunlight and then try to erase it and notice it's still there? Well, we used to do that in the United States all the time. That was our pastime a long time ago. And it's interesting because the dye, the ink that you use in your pen, is a photosensitizer. So if you want to go out today and write nasty notes to each other and then go put it up in the sun and then erase it, it'll still be there on your skin. So something to do this afternoon. If you have a photosensitizer, you really want to be able to use it on patients. And in the United States, the first commercially available photosensitizer was called Photofrin. It's still around. It's made by many different companies. It goes under many different names. They don't always behave the same way from different companies, but the concept is they will usually react appropriately. And what you do for Photofrin is you inject a person, you wait about 48 hours, and then you light up the tumor. And what's amazing about Photofrin, as opposed to a lot of other photosensitizers, is that it's painless. So you can do a lot of outpatient treatment. And what people have learned in clinical PDT for oncology is that the newer photosensitizers, as we'll talk about, are very painful, so it limits your outpatient treatment. The problem with Photofrin, it takes a very, very long time to do a treatment. So if you have a single lesion, it takes about 20 minutes to give a therapy. But if you had 10 lesions, you know, it could take 200 minutes, and that's way beyond the capacity of a doctor to stay awake, so we don't like that. The other problem is that the drug itself stays in your skin for at least 6 weeks. So in a place that's very, very bright and sunny like Brazil, it's very hard to use a drug like Photofrin. In a place like Buffalo, where it was discovered, they only have 2 days a year there's sunlight, so it's no problem there. So what really happens is with PDT and Photofrin, it really works beautifully, and that was the engine for future PDT. That's the structure. I'm sure you're all familiar with it. It's a porphyrin. And what's really interesting about this is it has several wavelengths based on its structure that it's clinically active in. But you can see from singlet oxygen production, it's very, very active at 400 nanometers in blue light. But in red light, which we use in the clinic, and we'll talk about that, why we do that, it's not very active. So the search has been on since the development of Photofrin for more active sensitizers, again, because doctors have very, very short patients, and they can't do it for more than 5 minutes. So one of the newer ones was ALA. We'll talk a little bit about that tomorrow, but ALA is very interesting. Aminolevulinic acid, it is a prodrug that's converted in your body to several very potent photosensitizers. The one that we talk about mostly is proporphyrin 9. So ALA you can put on as a cream. It's very popular that way. You can eat some of it, and you can also be injected. So it's a very versatile photosensitizer. It probably is a growth engine for the future, too, because of that versatility. There's a very, very efficient photosensitizer called Phoscan. Comes from plants. That only takes a few seconds for treatment. So it's very good for the surgeons. They love it, because by the time they're ready to go, it's all finished, and they're on to the next case. A drug that's very, very common in the United States, but not so common anymore, is verdiporphyrin, which we'll talk about in a little while. It's a very interesting drug. It's vascular targeted Pdt. It goes to blood vessels. And there are many, many drugs that are or used to be in trials, but are not commercially available. All those drugs have very interesting characteristics. They probably could help a lot of cancer patients, but the problem is you can't get them, you can't use them. So you're stuck with the ones that exist, and you need to use the ones that exist. Once you have a drug, every drug has its own characteristic intensity and wavelength of light that it likes. So if you're thinking about this, you might have to have 6 or 7 different lasers if you have 6 or 7 different drugs. That's very expensive. So generally what happens is somebody will become familiar with one photosensitizer, buy the equipment for that one photosensitizer, and stick with it. But any sort of light that gives you the appropriate wavelength and energy, so it could be sunlight, LEDs, lasers, anything that gives you that energy will be successful. There's an interesting number of studies that are coming out to use sunlight to actually treat patients for PDT on the skin. And it's a very, very interesting and good concept because sunlight is free if you can measure it, and that's the hard part. But if cost is an important aspect of PDT, then the sun is free. That's a great way of cutting costs. For most patients who are getting cancer treatment, sunlight's the enemy because it will activate the photosensitizer inappropriately in inappropriate places and give you a nice sunburn. And when we use light, we have to bring it to our target. And in the last couple of decades, fiber optics have been developed that allow the light source to go down through biopsy channels or endoscopy units to get the light any place you want. So when I started PDT, which was not too long ago, we had these very, very large tools. Not only were they gigantic and did they require special electricity and special cooling, but they didn't work too well. They wouldn't turn on. So you injected a patient, and the light source wouldn't go on. It was a crisis. About a decade or more ago, a more reliable type of unit, also a more portable type of unit, came on the market. And this is a common unit today to do PDT because it gives you this false sense of success. It tells you what light dose and what amount of time. So there's a computer algorithm in there that allows you to feel like you've really done a good job, even though that number that appears on the screen really has very little to do with what you're doing to treat the patient. We'll talk a little bit about that too. But what was most impressive is that the fiber optics, as you see here, could be attached directly to this portable unit. So you could do this treatment in your cancer center. You could bring the unit to the operating room. You could take it to a field hospital. So having units like this, and again, this is relatively large compared to what's available today, you have a very, very versatile treatment unit. So more and more of PDT is becoming more advanced light sources more than anything else because it's very expensive to develop drugs, a little less expensive apparently to develop light sources. So for cutaneous treatment, you have these LED light shields, and you can miniaturize those and put them down endoscopes too. And you could have something like this, where again you have an array of these fiber optics, and that's Dr. Doherty, the inventor of modern PDT right there. He's holding those fiber optics. You can put those fiber optics any place the tumor is. If you have a tumor on the skin, you could use it for the skin like a flashlight. You could take those fiber optics and stick them down your nose, down the mouth, into biopsy tools. Any place the tumor is, those fiber optics can go. So you can treat any place in the body these days. One of the things that we don't think too much about in the clinic is what is the light doing. And often for cutaneous treatment, there's a tendency to use blue light. Now, as you remember from Photofin, also from Allah, blue light really activates that drug, gives you a lot of singlet oxygen, so it's also quite painful apparently. But the blue light doesn't penetrate too deeply. So if you have a very superficial lesion, using blue light allows you to control the depth of penetration. Here's a green light right here on this laser. What's interesting too about the laser, this is simple for you, hard for me, but you put the laser, it's powerful, but it doesn't come through, so it really does not have very much penetration. If this was a red light laser, that costs like an extra $1, that'll go right through. And most interesting, if you take a flashlight, which is white light, and you stick it under your chin here, and you get what happens? You look red, because the red light penetrates your tissues, not because of blood. So you learned something today. Well, I could be wrong. Anyway, red light penetrates perhaps a centimeter in the clinic. In the laboratory, it really does not penetrate that much, but we've seen it go that far. And most successful photosensitizers in the clinic, historically, you've been trying to get lesions that are deep. So they like to use these wavelengths in the red and beyond. But there's problems with that because that light travels very far, relatively speaking, so you could be treating things that you don't really want to. It's much more elegant to bring the light source directly to the tumor and not have to worry about where the light is scattering at a distance. So again, what happens when you have the drug and the light and everything is working well, you create a photodynamic reaction so that photosensitizer in its inert state becomes active, and it can do a few things. One of the things that it can do also is lose energy and fluoresce. And one of the great things about fluorescence is that it could tell you where the tumor is and what it's doing. So a lot of times in the clinic, you have a tumor, you're not exactly sure where the tumor starts or ends, but if you have the means to fluoresce the photosensitizer, it will tell you, the tumor will tell you where it starts and ends because the photosensitizer supposedly is in the tumor, but not in the surrounding normal tissues. So you could use this fluorescence to guide resection. In other words, you only cut areas that fluoresce. That lets you spare normal tissues. You could use the fluorescence to guide your PDT. And supposedly, if the photosensitizer has destroyed the tumor, there's nothing left. So the loss of fluorescence could be a very good aspect to clinical dosimetry. We'll come back to that. But what the photosensitizer can do when it's active, it's got an electron in there, in that outer shell, and that electron can interact with oxygen, and that is the type 2 photodynamic reaction. That is what everybody spends all their money on, creating photosensitizers. The reason that we do that is because historically this type 2 photodynamic reaction has been what PDT has been all about. It might not be the correct way of doing things, but that is the way it has developed. The type 2 reaction with singlet oxygen has a very interesting concept behind it, is that singlet oxygen is very destructive, and your body has very, very great difficulty repairing damage from singlet oxygen. So having singlet oxygen produced in a tumor is a very good way of destroying things. You can do a type 1 Fenton reaction also, and again, a Fenton reaction is toxic, but the body has ability to repair a lot of that toxicity. The photosensitizer itself can be directly toxic, and this is sometimes called a type 3 reaction, depending on where you're reading. And the interesting thing about a type 3 reaction is you don't need oxygen, supposedly, for that. So in a hypoxic tumor, having a photosensitizer that might behave in a slightly different manner might be of great benefit. So what is the photodynamic reaction? Again, it's a type 2 reaction by definition. You've got singlet oxygen, and this starts to create a number of pathways of destruction, phagocytosis, apoptosis, necrosis. One day in the future, you'll be able to manipulate the photodynamic reaction to different pathways and do apoptosis, which is a localized sort of reaction, versus, let's say, a necrotic reaction, which releases a lot of chemicals to the body, and that upregulates your immune system and sort of creates a vaccine. So I wouldn't be surprised in the next 10 years that you use photodynamic therapy in a different way than we're doing today, which is pretty much a standard drug and light dose, and under the clinical situation, you might want to have a very localized treatment or something that creates a tumor vaccine. So again, what happens in an overview is pretty straightforward. You bring in a photosensitizer to your target. Ideally, the photosensitizer is smart enough to get there by itself. Then you have to bring the red light in. That's the hard part, making sure the light's there. And if you bring in an appropriate amount of light at the right energy, hopefully what you do is activate the photosensitizer, create that singlet oxygen. That free radical is very nasty, and it will destroy things in its path. Ideally, the photosensitizer is in the tumor to a much, much larger extent than it is into the normal tissue, so that you'll have between the localized light and the localized photosensitizer a very, very select reaction. Sounds better than it really is. So let's talk a little bit about where this all came from. There was a very smart medical student who was using dyes, and he discovered that with very intense light, the dyes would destroy things in its path. And rather than just shutting down the light source and doing his experiments with lower light, he explored why that more intense light would destroy things. And then, like all good professors, they stole it from him and determined what it was. And by the early 1900s, patients were being treated with PDT. At the same time, other researchers were looking at porphyrins and their fluorescence and did PDT on self-injection like the other good professors do. So, half the professors take your stuff and the other ones inject themselves and do good work. So around the turn of 1900s, thousands of patients were being treated with PDT. For whatever reason, it was lost to medical science, and it was rediscovered, incidentally, in the late 50s and early 60s by some individuals who were very bright at the Mayo Clinic, and they were looking at tumor fluorescence and did a little bit of PDT. They were actually looking at these items, these porphyrins, as radiation sensitizers. And interestingly enough, that was lost again. In the 1970s, Dr. Doherty retired as a chemist, and he started work in the radiation biology lab at Roswell Park Cancer Institute in Buffalo, New York. And his first experiment that he was taught, he was said, you're going to use this chemical, which was photofrin, but nobody knew it, as a radiation sensitizer. But don't ever inoculate the tumor cells near the window, because all the tumor cells die before you give radiation. And they had been doing that for about 5 or 10 years, and he had the discovery of, hey, the light is killing the tumor cells, isn't that what you really want? So he rediscovered PDT, which was apparently in that lab for at least a decade, but that's the difference between a genius and the rest of us, except for Vanderlei. So this is an example, apparently, if you believe it, of the very first reported treatment. And it was a white light, but very intense white light. And white light contains all the different spectrums, so it was intense enough to activate the dye. And today, this patient might go for some cosmetic surgery, but that was a nasty tumor, and it's gone. And that's a great success. If we were able to do that treatment today on a regular basis to a lot of our patients, we'd be very happy. So this is what you could get in the early 1900s. So without the plastic surgery that we do today, this is still a very, very outstanding type of treatment. So what happened with PDT is it developed as a single treatment in the clinic because you had that gigantic laser that you couldn't really get anywhere, and you had to bring this anesthetized patient up to a laboratory. It was very, very difficult to do all that. So you got one chance, and you got a very, very intense illumination. So first, it was a lot of intense treatment to the skin, but as the fiber optics developed, you were able to do deeper and deeper treatments. So the current technology, interestingly enough, allows for quite a few different ways of doing treatment. You could repeat it. You could give it at lower doses. Because of technology, your light source is not necessarily your limiting factor anymore. So I think you'll see in the near future PDT being given differently than it had been classically. Why? Because classically you got one chance to do it, And that was it. You had to take your best shot. So what did you do historically? You gave the drug, you waited for the drug to accumulate, and again, this is an interesting interval. That's the drug-to-light interval. It's different for every drug, and you can manipulate that, but classically for photofrin, you'd wait 48 hours. Why? Because the drug would get out of the bloodstream and concentrate to a certain degree in the tumor, supposedly, and then you'd bring the light in. So the drug is concentrating, your light's in the right spot, you get a localized reaction. Well, you know, what happens is if you wait just an hour after you inject photofrin, it's in your bloodstream at very high concentrations, and it's in the bloodstream of the tumor in very high concentrations. So the same drug, photofrin, delivered 1 hour after injection, behaves very much differently than that drug, photofrin, delivered 48 hours after delivery. So I think in the future, too, you'll see a lot of manipulation of this drug-light interval to change the way you can clinically have tumors respond. So what do we do in oncology these days? We still consider PDT to be a local treatment. Now, we all know there's this downline reaction with cytokines released, and probably there's a vaccination that the PDT does that primes your body to attack the tumor. But we consider this a local treatment. And we also consider PDT where it's going to be delivered. Is it something that's going to interfere with function or cosmesis, or is PDT going to give you a better outcome? So what's happened, a lot of PDT has moved to skin cancer because PDT gives fantastic results in the skin. Not only does it destroy the tumor, but it seems to regenerate some normal skin. And probably, as we'll talk about, I think the future of PDT for the skin will be more rejuvenation than it will be for cancer treatment. What's also interesting about PDT is that there's not a histology, there's not a type of cancer that won't respond to it. So sometimes in radiation we say, well, melanoma doesn't respond well to radiation, or this doesn't respond to that, or that doesn't respond to this. But for PDT, no matter what type of tumor you have, as long as you get drug and light in there and you can get that reaction, it'll destroy it. And what also we look at PDT is we originally use it as just as a salvage treatment. In other words, a treatment when all other treatments have failed. But a lot of the best outcomes with PDT is to use it up front, and that's something I hope grows as well throughout the world. What do we worry about when we do PDT? Well, again, if you have a lot of tumor in your body and you're doing a local treatment on somebody, does that really benefit them? Well, sometimes it does if that local spot really hurts, or if that local spot is going to shut their airway off, then a local treatment in systemic disease is very successful. If the patient won't stay out of sunlight, in other words, when you're preparing to inject them and they sign the consent form, if they start laughing when you say, well, you have to stay out of sunlight for 4 to 6 weeks or something, that laugh is very important. Don't give them that treatment because they will not stay out of sunlight, and all your good work will go down the tube because they'll get burned the next day even before they get their light treatment. Because once the photosensitizer is injected, you're photosensitive. Another thing about PDT is it creates a wound, so it replaces the tumor with a wound. So if you've got a wound that's very large, for example, and you have a patient who you only think is going to live another month, you might have just replaced a tumor with a wound that won't heal. You might not have done them any good. So you always try to think about, are you going to help the patient? One of the big precautions, too, is depending on the photosensitizer, you can have a lot of pain from PDT. Again, photofrin, for good luck or whatever reason, is a relatively painless treatment, but a lot of the photosensitizers out there, you turn the light on, the patients start to scream. So sometimes anesthesia is required. That's very, very important. One of the things that we should do is fluoresce patients. I know that you guys have tools to do fluorescence. In most of the world, there's very, very little fluorescence that's going on, and that's a shame because fluorescence can help you determine where the tumor is, how you should target it. There are changes in the tumor, ideally, during fluorescence. The fluorescence should change. You'll feel comfortable that you're doing a successful treatment. As our previous speaker said, you could use some fluorescence changes as an optical biopsy. In other words, right now, you have to do histology. If somebody comes to you with a skin lesion, you can't really feel 100% confident what they have on their skin unless you do a biopsy. You can feel very good clinically because you've seen 1,000 before to render an opinion, but if you really want to know what's going on, you got to stick a needle in, you got to wait 3 or 4 days. People get very nervous. If you had an optical unit that you just shined a light on, and it could give you an answer whether that was benign or malignant in a second or two, that would be a great advance for medicine and also prevent a lot of unnecessary biopsies. So fluorescence, as you go on in the world of PDT, you should make that grow because it's so important. So what do we do in the clinic? Well, for oncology, we've stolen this paradigm that was discovered and described for verteporfin. Verteporfin is a vascular intense photosensitizer. It goes to neovasculature. And the geniuses who discovered this did a study of where is a very common tumor or type of medical problem where neovasculature is causing grief. Well, it's in the eyes. It's called wet macular degeneration. You go blind from this, so you get these leaky blood vessels. It's leaking out a lot of fluid and blood. You can't see wherever it leaks. So very, very innovative use of a new type of treatment. Found out that you could stop the progression of disease or slow it down. Did clinical trials that proved that it worked, and then went one step further. Every ophthalmologist at one time in the United States and around the world would have a tool to light somebody's eyes up. So it was very easy. They could get the drug, they knew what the dose was, there was a clinical trial that proved it, and the tool was in their office. So this was a great paradigm for PDT. And the problem with PDT today is you might have a great drug, but you don't have the right dose. You might have a great drug, but you don't have the right laser commercially available. So even though about 25 years ago this was all worked out, it was still lost. And that's probably a great problem with PDT in oncology. You never seem to understand the history of it. But despite all these shortcomings, there's been some really, really good response in PDT. So we'll start at the head. And a lot of different drugs have been used, but the common ones are ALA, Photofrin, and Foscan. And originally there was some resection of the tumor because in brain you usually have a single tumor that kills you. It's not really benign or malignant, but it kills you. Some are more aggressive, they're considered malignant, but even a benign tumor in your brain will ultimately cause your demise from local problems. So the surgeons will go in and remove it if they can, and interestingly enough, it's very, very difficult or impossible to tell where normal brain is and tumor starts because the brain is complex that way. You can fluoresce. You can put in a photosensitizer and fluoresce and determine much more accurately where normal brain is and where tumor is. And then you can do a fluorescence-guided resection. Now you can imagine that saves a lot of your brain because previously the surgeon would go in, do a gross total resection of whatever they thought was abnormal, and then they start sucking your brain out. Now some of that brain actually is useful. So when you use this fluorescence-guided resection, you can suck out less of your brain. And not only do you suck out less of your brain, so in other words, you wake up a lot better, but you live longer because apparently they've done a better job at removing the tumor. So fluorescence-guided resection is growing, and interestingly enough, despite some of the work by Dr. Wilson, the PDT part is now coming back, which seemed to have been lost for a while as well. So the state-of-the-art for brain tumors in certain parts of the world is to have fluorescence-guided resection followed by PDT. And how that will work out in the future is unclear, but it certainly is really quite promising. Head and neck tumors, we have, again, world authority right in the audience, Dr. Hopper's work. So in situ, early invasive, recurrent tumors all respond beautifully to PDT. So if you're available in a PDT center or a region and you have an in situ tumor, PDT is phenomenal. Why? Because generally the best way to treat in situ tumors, again, those are not invasive tumors, is to start cutting. The problem is these in situ tumors, you don't necessarily know where they start or where they finish. Plus, whatever's causing this in situ disease, usually some viruses, they're multifocal. So yeah, you say, well, a little cut here, a little cut there, but after a patient has had 10 or 12 surgeries, which is not uncommon, they might be missing half their tongue. They can't speak, they can't swallow, they're deformed, all because the surgery has been classically the best way of doing things, but fortunately with some really good work from Dr. Hopper, you can just do PDT and get a very, very good outcome and retain function. And he'll show you a little bit more about that this afternoon. Tumors that are early invasive, you have a bigger surgery. So even though you have a tiny tumor, you might have half your tongue removed. It's very hard to swallow and talk when you have stuff like that. Yet you're cured, but the side effects are severe. As an oncologist, we only usually think in terms of, well, we've cured them. What are they complaining about? Well, they're complaining about because they can't talk to their family. You can take PDT and you could do a very, very fine job, probably equivalent to surgery in a selected cancer, and not have all that difficulty swallowing or talking because the tongue is still there. Larynx cancer is interesting because larynx cancer generally stays in the larynx. These other cancers in your body might spread to lymph nodes. And right now, PDT can only treat locally. So if you have a tumor that's in your tongue that's spread to your lymph node, you still need to have that lymph node taken care of. But for the larynx, it's very, very rare for that tumor to spread. It just grows locally. And PDT is phenomenal for larynx tumors. Not only does it get rid of the tumor, but apparently your voice is preserved. And that might not make a whole lot of difference to everybody here, but there are people who make a living on speaking, and those individuals will seek out PDT because they understand how good it is. One of the more interesting aspects is that recurrent disease in the head and neck. If you have a tumor of the head and neck, you have to live a very long time for it to metastasize to your body. Most tumors of the head and neck grow back locally or regionally and kill you there. And it's a very, very nasty demise. And what was very well-designed trial used Foscan, and just a single or two treatments with PDT gave you not only better salvage than all the chemotherapy that could be thrown at them, all the radiation, all the surgery, but if you did a good PDT, in other words, the PDT was felt to encompass the entire tumor, you tripled their survival over patients who had got chemo or radiation as salvage. So interestingly enough, if you've got something growing back and it's local and you can do a good PDT treatment, for whatever reason, that'll give you a very much better outcome than what seems to be available otherwise. And unfortunately, despite all this good stuff, you just got to fly to London to meet the king to get the treatment, because it's very rare to get that. That would be you, to get this treatment. It's unfortunate, but that's the way the reality has worked. And hopefully a lot of this will be available here in Brazil, because it's such a good treatment and it's such an underutilized treatment. This is a typical example. This is what we do. We use a little bit lower dose of drug because we think that's an improvement in treatment, because less drug means less drug to normal tissue, but the tumor still picks up the drug. So here's somebody with a lot of in situ disease. You can already see they've had a lot of surgery. And what we do is we illuminate the tumor bed, and because we think with less drug it's more selective, we see the areas that we felt had tumor reacting more, and then it recovers, and we biopsy this patient, and this patient has done wonderfully well. Unfortunately, came back for a second treatment in a different spot in the mouth and also did well there. So head and neck tumors, particularly in situ disease, PDT is fantastic. Some of the earliest trials in cancer were for lung, and initially obstructive lesions were used. And obstructive lesions, you can't breathe. You die very quickly. It's a very nasty way to die. A lot of times you cough up blood. Your family gets very upset. Why not? Because they love you and you're coughing up blood and nobody can do anything. Well, you do a single PDT session. Generally, the blood stops flowing and you can start to breathe. So PDT is a godsend, a wonderful thing for advanced obstructive disease, but it also works wonderfully well in early disease. So in early disease, there's a lot of surgery that goes on, and despite the best attempts with robotic surgery, there's still cuts and bruises and recovery. There's radiation that's used with radiosurgery, and despite that very advanced radiosurgery, it's a very difficult treatment to recover from if you have side effects. But PDT, you just get the PDT, you're back on your feet within about 24 hours, and you're feeling a million times better. So PDT is an absolutely wonderful treatment for early and advanced lung cancer. There's a lot of competition with other types of treatment, but still, it's fantastic. This is just a relative example. Here's a patient. This is the airway. You're looking down their throat, down their airway. There's a bronchus that's open, and there's a bronchus with a big, ugly thing. There's a fiber optic being shoved into the ugly thing, and lo and behold, 24 hours later, it's wide open. You can imagine you'd be breathing a whole lot better. And that's a very typical response for PDT in the lung. That's why it's fantastic. You can do it for esophagus. There are microinvasive and relatively risky diseases like Barrett's esophagus, which has a high propensity to become cancer. Esophageal cancer is very nasty once you get it. To be cured of it is very, very difficult. So if you can catch it when it's early, like in Barrett's stage or in situ stage, PDT is excellent for that. But PDT is also great for obstructive esophageal cancer. It really opens up the esophagus, lets you swallow, gives you a good quality of life. So for lung and esophagus, PDT is phenomenal. It's been tried in a number of other areas in the belly. Cholangiocarcinoma is a very rare tumor But if you get diagnosed with cholangiocarcinoma, you generally die from it, and you die in a very, very miserable way with something called cholangitis. You turn yellow, you have a lot of fever and pain. And what you do with PDT is you take the fiber optic right up to the tumor where it's obstructing, and you put it right into that tumor. You open up the bile ducts, the bile drains, and within 24 hours, you go from on death's door to feeling very good. And if you do several of these PDT procedures, instead of dying at 8 months, you might be alive at 3 years. So if you think about it, you get to see your kids grow up a little bit, you get to see your family for an extra couple of years. It's phenomenal. It's underutilized again. It's been tried to treat liver disease. It hasn't worked out too well. It's been tried in the pancreas. It hasn't worked out too well. And then it's been tried in diffuse abdominal disease. It hasn't worked out too well. Why? It's very, very difficult to get the correct dose and light sources in. So as technology advances, probably these areas will be successful for PDT, but right now, because of our limitations in drug dose, light dose, and dosimetry, the clinical outcomes are more morbid, too many side effects to be of benefit. Prostate cancer is extremely common, and the treatments available today are successful, but very morbid as well. You could have surgery, generally removes your prostate. What happens then is you have no longer any sexual function. You also leak urine. You could have radiation. It could injure your rectum. It could injure your bladder. So it would be nice to have a technique that just treated the prostate and kind of left everything else alone. There was some very, very interesting initial studies with a drug called TUCAD, which has been replaced and revised, but so far it's been a little bit too morbid to become standard of care or even considered an option. But as dosimetry has worked out in PDT, the idea of the right drug dose, the right light dose for any given individual, no doubt that prostate treatment with PDT will come back to the forefront. What's interesting, too, is bladder cancer was one of the first areas that PDT was approved for. The problem in the bladder is that even if you have a disease that's not invasive, your bladder comes out. So if your treatment for bladder cancer, even if it's not invasive disease, does not work, your bladder's out, and you can imagine what kind of life you have after that. It's a totally different life, but it's a life. So most people will have their bladders removed. It would be very nice to have something that could keep a functioning bladder in. And the original studies with PDT showed very good response rates, but because of overdosing to certain areas of the bladder, there was too much fibrosis. Now there's very, very promising work using ALA derivatives. These don't penetrate as deeply. So what's interesting here is they use hexylated ALA, and that fluorescence the tumor. The surgeon goes in and removes the tumor. Sometimes that can be curative, but today a lot of patients will then get PDT to that area and not have the fibrosis. So I think PDT for bladder cancer, if it works out, will be a life-changing treatment for a lot of patients. Skin cancer, PDT is extremely common, but it's not done right. So there's a lot of room for PDT improvement in the skin. Classically, photofrin had been used. It's very, very potent for skin treatment. It penetrates all the tissues. If you have a bulky tumor of your skin, a thin tumor, but again, you have 6 weeks of light sensitivity. ALA is usually topical to the tumor or the area of interest. You wait about an hour, and then you shine the light. It's very, very comfortable, relatively speaking, for a patient. They go in the morning, and by noon, they're finished with their treatment. The interesting thing about ALA is it penetrates your tissue and concentrates in tumors at different rates. So by just using it at an hour, because it's convenient, is not the right answer. There's more ALA in that tumor at 2 hours. There's even more at 3 hours. The original indication for some of these treatments was the next day. Why? Because that's when they found most of the ALA concentrating in the tumors. Yet the dermatologist, because it's not convenient to do stuff one day and do another treatment the next day, they kind of have changed this in the clinic, but that's not necessarily the most appropriate way of doing it. Probably the best way of doing it is using the fluorescent meter, seeing how much ALA is there, and then you can individualize the treatment. Some people metabolize better, some are slower, so you can optimize a treatment just by a simple tool. And yet that simple tool is not available in most of the world. So you guys will be leaders in that when you show that you optimize fluorescence and you prove that it's being done. Then you'll use the meter after treatment to show there's no longer any fluorescence and feel very comfortable that you've had a successful treatment. So there are many randomized trials showing that ALA in various forms works for superficial treatments, but there's much, much room for improvement, and I think you guys will be leaders in that in the near future. So just some simple clinical outcomes from the skin. Here's a patient who had a number of thick lesions on their skin and actually underwent photofrin treatment, and you have beautiful scar-free therapy. This is a lady with breast cancer who had recurred on the chest wall. As you can see, a lot of surgery bilaterally, maximum radiation bilaterally, 3 or 4 different chemotherapies, and all of these little knots, all of these little areas are tumors. We biopsy a few of them, but you know by feel that these are all tumors. That's a port for chemo. And this is the treatment that that patient had. We had a lot of laser power, so we just marched down the chest wall with the lasers, and a couple of months later, you could see that patient has had fantastic healing despite having had all that surgery and radiation, and she got lucky because we were able to ablate all those chest wall lesions. What those chest wall lesions will do is they will grow, they will fungate, they will smell, and they kill the person. So a simple outpatient treatment like PDT can save somebody's life. That's why it should be available. What's going to happen in the future? It's already happening now. Tumors are hard to treat, but there are other things that can be treated like bacteria and virus. I wouldn't imagine one day in the future that you're just going to be sprayed with some photosensitizer and walk through some light field to go into your research lab in the future. You'll use PDT to rejuvenate, heal. You'll use more fluorescence-guided resections for PDT. The thing that really needs help right now is accurate dosimetry. You've had quite a few lectures on that. That's a really hot area that really is important for the clinicians who have no clue what they're doing. Having that dosimetry would be wonderful. New light sources and photosensitizers, that's wonderful too. That costs a lot of money. Having ones that you have available now and using them properly would be much better. So what's the future for PDT? Well, these innovative light sources that you're going to be able to put around tumors and implant, and maybe they'll be digested by your body, so you just implant that light source next to the tumor. Hopefully one day you'll be using light from Mother Nature because it's so inexpensive, but I think the future is very, very interesting for PDT that way. In the United States, PDT is competitive with other modalities, and people don't appreciate it, but in areas where you have opportunity to develop PDT as a complementary treatment, what's ideal for a particular patient, it might be PDT in this case, it might be radiation in that case, but having all of that available for patients, that's the way you give really good cancer treatment. So I thank you very much for your time. And I'll just remind you, if you have a question, it's holding up lunch.
Any questions?
Hello. I have a question about the metabolism of the photosensitizers. So where will these molecules eventually go? If they go to the environment, maybe it will goes to the food chain, to plant, to animals, even eventually to the human beings. So will it to some to
That's
be
right.
harmful?
That's why you got to watch drinking the water because you never know what's in there. But it's true. A lot of it is, every photosensitizer behaves a little differently. Some are metabolized by your liver into derivatives that might be more intense photosensitizers. Some are destroyed in your liver. Some become inert in your liver. Others go through your kidneys and are excreted through the urine. And it's probably an issue that people should look into more, but I don't think anybody does. And if you look at ALA, you get the protoporphyrin 9, but then you get urobilinogen and things that will become very intense and go out as active agents. So yes, it's important to think about that, and I don't think people think too much about it because porphyrins are like blood, and there's a lot of blood in the environment, and people they use precautions, but a lot of it gets flushed down the toilet too. But you're absolutely right. But every photosensitizer is metabolized differently, and it's a great question.
Thank you.
So, Ron, I would like to know what is your opinion concerning why PDT is still on the early stages, why this is not something that we can find everywhere.
Yeah, so...
and there is a second question that you can answer in this
I don't know if I can I remember it? You want to
yeah, it's very simple. The second one is, what is a complication that you got very surprised when you found? I mean, over necrosis. Give you one example that you were very surprised with the PDT result.
Well, So why PDT hasn't grown is interesting, because I think a lot of what happens, for example, in North America, is you have a pharmaceutical company that is a strong supporter, and they do a lot of things that you don't know about in the general public. They do lobbying behind the scenes, and they create billing. So photodynamic therapy never created good billing codes. And in places where you're paid for your service, in other words, fee for service, you could do PDT all day and you wouldn't get paid. Now, if you have bills to pay, like you do in private practice, you can't do that. If you're subsidized by the university, you might be able to get away with a little bit of that, but certainly not all of it. So the companies that were responsible for getting good billing codes, which are the same companies that behind the scenes are promoting the drug at conferences and helping publications and things like that, they failed miserably. At the same time that they failed miserably, other companies were developing other forms of the electromagnetic spectrum, like hyperthermia, radiofrequency ablation, microwave ablation. All of these things are very difficult to control dosimetrically, yet they have better billing codes. So you'll see a lot of radiofrequency ablation being done by people. They just put the probe in, turn the heat on. They don't know where it's going. If you don't heat right or ablate right, you form a zone of resistant cancer cells. So you're probably actually injuring some patients, but that's not followed because there are no clinical trials. So PDT was approached in a totally wrong manner. It's still approached in a wrong manner. And unless some company comes, or some genius like you, Vanderlei, comes across and does it right, it's just going to sort of die in civilized areas where they think spending $20 million for several surgical suites is the right way of doing it, when they don't understand that same $20 million could have treated, all the uninsured patients with skin cancer for 2 years. So there's a relative value system that's just screwed up in a lot of countries. And unfortunately, the guys who did PDT back in the old days totally screwed that up, and I don't know if it'll ever be recovered. Now, in terms of doing PDT, originally I did it at 2 milligrams per kilogram, and that's a very, very potent way of doing treatment. So what we found a lot of times in the lung is that patients would have a very vigorous response, and they would get into an emergent pulmonary situation. It's supposed to happen only at 48 hours later, but it can happen at any time. On the other hand, when we went down to 0.8 milligrams per kilogram or 1.2 milligrams per kilogram, which is off-label treatment, hardly ever had that vigorous response in normal tissue. So I think the major drawback to PDT at the standard drug dose and light doses, it was designed for single treatment to ablate whatever was in its path and hope that the normal tissue would recover. But I think that's also a great downfall for PDT, because nowadays when you do a radiosurgery procedure, you're treating within a millimeter and you're leaving normal tissue alone. When you're doing a operation with a robot, you have the ability to be very precise to a millimeter or two. So you're leaving a lot of normal tissue alone. So the other types of treatments have improved, and PDT on standard drug dose and light dose has not. So I think, to me, you have to use your brain in the clinic. You have to change the drug dose and light dose. Having the fluorescent meter and having a physicist to help the clinician understand that it's just not turning the light on and off, that's the key to successful future PDT. Because when we turn on the light, when we plug in and program on our Diomed laser, 18 minutes of treatment, we felt like, yeah, we're giving that. But who knows what we were really delivering? Because that light was here on one patient, there on the other. You never know what you were really doing. So I think a closer scientific aspect to clinical PDT would help a lot.
So that means that you believe in a real-time dosimetry type of...
Or close to it, or just
Okay.
much better than what we have now.
Okay.
And what about natural photosensitizers? Are they available, or is just a project?
Well, there are probably a dozen photosensitizers that have gone through clinical trials that have proven drug dose, light dose, and outcome. And of those dozen, if there are 3 or 4 or 5 that you could purchase, that would be about the most. So there's another half a dozen really good drugs that have already proceeded through millions of dollars in expenditure, but they're sitting on some laboratory shelf. So Mother Nature provided quite a few excellent chlorines, bacterial chlorines. They're all superb. And again, Photofrin is available and relatively cheap to make. and ALA, again, is available and relatively cheap. So you've got a handful that are really great. And to search for new ones with bio-nanotechnology and all sorts of wonderful things that you could do, hopefully you got really deep pockets, because the ones that are available not really being used too well, and to think about bringing a whole new set on, that's very expensive propositions.
Thank you.
Doesn't mean you shouldn't do it, but you just won't get anywhere.
So, Ron, what's your opinion on using PDT in combination with other cancer treatment modalities?
Yeah, so PDT, I think, is one of the phenomenal treatments that is complementary to all the others. We've used it with radiation, and you use it with surgery, intentionally or unintentionally. You can use it with chemotherapy. So it works really quite well in the spectrum. And if you had an open mind and PDT was available, it would be really fantastic for select patients. Like, again, the in situ lesions of the tongue, oral cavity, that's where PDT could really be wonderful. Save a patient dysfunctioning mouth, but it's not necessarily available, so most of the time it's just cut out. So it's nice to have the opportunity to have all of these available for that individual patient, and that's the other big problem with PDT. It's not viewed as part of it, it's viewed as, let's do this.
What effect does chemotherapy or even anesthesia have on the uptake and the actual light exposure?
Yeah, so you'd have to be thinking about that. And a lot of times there's no real thought given to that at all. And there's very, very little data. So there are some chemotherapy agents that give a sort of a recall reaction with PDT. In other words, you get an inflammatory response way wider than you would have thought. So there are aspects to that. There's interesting concepts that go along with that. So instead of just blasting somebody with chemotherapy, you could give a very low dose, and you might get some talks on that, and use photodynamic therapy to bring the chemotherapy right to the spot by damaging the cell. So photochemical internalization is a popular name for that. So you could actually use the properties of the photosensitizer and the light to improve the chemotherapy. And again, anesthesia, what does that do? Sometimes it constricts vessels, opens vessels, so you have to worry about blood pressure. That certainly does also change the way the photosensitizer is going to be circulating. So if you're going to do a very fast vascular PDT, it would be nice to have a fluorescence meter to tell you that there's some photosensitizer in the tumor before you just turn the light on and assume it. Fortunately, drugs like photofrin are just way smarter than we are, and they seem to know where to go. So fortunately, despite our lack of knowledge in the clinic, the drug and the light works quite well. But it would be much better to have that as part of the variable and to understand that. And that's just not part of the equation for most people. Although Dr. Hopper, with a lot of surgery, probably understands that's far better than most people. And hopefully he can give you a comment this afternoon. If you have a photosensitizer and you have a pulse oximeter, it's a red laser. It could be intense enough to give you an interesting burn on your finger. So that's my extent of knowledge of how things can change. But that's just subtle, and he'll give you some more stuff on that. Thank you for that question.
And I was unaware that some of the animal anesthetic agents have a significant impact on PDT. Clinically, I take the simple view: you shine light and you kill tumor. But was this some?
This is nothing. The comment I made originally was nothing to do with PDT. But we were doing some work using luciferase, which is a bioluminescent rather than a GFP. So it's a microscope. And we built a miniature probe for imaging the pituitary gland. And we used it in one university brilliantly. Huge signals, worked beautifully. We then did it in another university, and the signals were down by 100 times. And eventually, I just asked a question, well, what's different? And we discovered they were using a slightly different anesthetic. And it was clear that the anesthetic, we've done more work on it since, but the anesthetic was affecting the cell dynamics and the way that the luciferase and the ATP and all the other parts were taking place. That's why I asked the question, how does the anesthesia affect the PDT? And I'm willing, from my experience here, to say it makes a big difference, because what we did notice with the slightly different anesthetics when you look up part of it, it affects the oxygenation within the cells. And therefore, the concomitant thing is, one assumes, therefore, it potentially has an effect on the thing. And I know there are also other treatments where people worry really about local anesthetic, but this was gross, total anesthesia. I accept the comments I'm making were in rats. The interesting thing was when we first submitted the paper, one of the reviewers came back and said, well, this is well known. So we went, where is it cited? And nobody, we couldn't find it anywhere looking at from a number of different directions. And I think there might be something in this. But that as I said, it's noted from an animal study, but it might be worth taking on.
Hi. Nice presentation. You said that in the future there's going to be a new develop of photosensitizer, new photosensitizer. I was asking, in your opinion, what would be the new improvement of that photosensitizers? Should they go by another mechanism, or should they, I don't know.
Well, what I have come to conclude is that the photosensitizers today are on these longer wavelengths, so you get better depth. So I don't necessarily agree with that, because those light photons, you can't control where they're going. So what I would do is I would create a 1-2 particle. Part one of the particle is the photosensitizer. The second is a key, which is the light. And then you could use blue light or whatever, because everything is within millimeters, and you don't have the normal tissues. So I would look at the other wavelengths this way rather than that way to get a more precise type of treatment. And then put a nanoparticle in there, because you get a publication and people give you money if you say nanoparticle.
Right, so you partially actually answered my question, which was about the use of the nanoparticles for the PDT. So you think about more like gold nanoparticles, or the combined with the photosynthesizers?
Well, yes, that's an interesting thing too, is because photosensitizers, as I'll talk tomorrow a little bit about photosensitizers, as they can do a lot of different things. So if you did something that was, let's say, paramagnetic, not only could you do PDT, but you could heat it up and you could image it with MRI. And so there's a whole lot of things you could do. Whether or not this would actually eventually get to the clinic, I couldn't tell you, but it's really interesting stuff, and it would help explain quite a few things. And I would think having something that can do several different activities would be clinically really quite relevant for now and the future. So having a nanoparticle, a heat, whatever you think of. People have tried to tag toxic substances to it directly, but it seems the body finds the toxic substance first and destroys it. So the photosensitizer is a really good targeting agent as it is. So I wouldn't want to hurt the photosensitizer by putting something else on it that made it less targeted.
Thank you.
Thank you, Professor.